Good evening and warm welcome to dear delegates across the country on the forum Diabetes and Beyond. This is in continuation with the scientific series program DIA 5 and the Panacea Biotech from the Dakar division, which is catering to the diabetes drug. We are here with the diabetologist, endocrinologist for more than 2 decades. With the launch of the glycoside amongst the first generic, we are in association with the diabetes care and all the diabetologists across the country with metformin, vildagliptin, and now with the Hlt2 Dapagliflozin. In continuation with the academic activity and providing the scientific forum to the topmost academicians in the specialty of the field. Today we have the interactions with the other specialties where the diabetes is the common problem for the complications of the various systems in the body. So today we will discuss pertaining to the diabetic kidney disease. We are talking about the complications and managing the anti-diabetic drug therapy, which is having the pleiotropic benefits. Today we see that the anti-diabetic drug is having its actions beyond its glycemic control. And the diabetic patients are having the morbidity and mortality for the organ failure, importantly the kidney failure or CKD. For this, we are having to moderate these sessions. We are having the Dr. V. Mohan, and today's eminent speakers are Dr. Subhankar Chowdhury and Dr. Vivekanand.
Recording in progress.
Oncologist amongst the country. Our today's chairperson, Dr. V. Mohan, is a known faculty in country and across the world, who is interested in the research with the epidemiology. The Indian diabetes data mainly referred with the publication of Dr. V. Mohan for more than 30 years. He studies in diabetic complications and genomics. Also special interest into the pancreatic involvement. He is a conferred fellowship from all of the 4 Royal Colleges of Physicians. That is very, very significant and showing its academic contribution, including the fellowship of Indian National Science Academy. The awards for his contribution to the diabetes management and care is recognized with the Dr. B.C. Roy National Award. So along with that, he is having the Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research from the ICMR, which is importantly having the research project on the molecular biology in the chronic diseases like diabetes. In 2018, he received Dr. Harold Rifkin Award from the American Diabetes Association, and he is the first Indian to receive this award. Very recently, he conferred the fellowship of the Royal Society of Edinburgh from the Royal Society of Edinburgh. His academic interest and his mentoring to the postgraduate student is very well recognized with his publication of the research papers and review articles and original research articles across national and international journals. And the chapters into the academic textbooks are also there in more than almost every medical textbook. His chapters are there, including the internal medicine. And his publications has crossed the more than lakhs account. 2012, Dr. Mohan has received the topmost award for the civilians who get recognized in the country is a Padma Shri from Government of India. He is the author of the book of Making Excellence a Habit, The Secret to Building a World-Class Healthcare System in India, which is published by a global publication agency, Penguin, and recognized and ranked as a bestseller. I request Dr. V. Mohan to introduce today's topic and today's speaker. Over to you, sir, Dr. V. Mohan.
Thank you, Dr. Kunal, for those kind words. It's a great privilege and honor for me to moderate this session where 2 outstanding clinicians from India, Dr. Subhankar Chowdhury and Dr. Vivekanand will be speaking. And thanks to Panesia for organizing this event. I think we are going to discuss what extra benefits you can get from anti-diabetic drugs like Dapagliflozin and Vildagliptin and the other drugs in that class. Next slide, please. So just to, so that we are all on the same page, we know that not only we have a huge burden due to diabetes, but an even larger burden due to chronic kidney disease in this country. Probably we have the largest number of people with kidney disease, and from about that we'll hear more from Dr. Jha, who's more qualified to talk about this. But if you take all cases of CKD in the world and in India, approximately 40% of all these cases of CKD are due to diabetes. And if you add high blood pressure, to which diabetes also contributes, then it's a significant number of all CKD cases which end in end-stage renal disease. And therefore, it's very important to prevent the CKD by good control of diabetes. Next slide, please. Next slide, please. So we know that earlier the drugs for diabetes were just supposed to do that. That's control the diabetes. So we had the old drugs, metformin, sulfonylureas, and so on. And then started coming the newer agents, of which in particular the SGLT2 group of drugs and Dapagliflozin in particular has been shown to have benefits beyond glycemic control. We all know about the effects on blood pressure, on weight loss, and of course on diabetes control. But drugs such as the SGLT2 in general and DAPA in particular have also been shown to be beneficial for CKD and to slow down the decline in renal function. That means it's working just like an ACE inhibitor or an ARB. And since that class of drugs came, the ACE inhibitors and ARB, we have not had a drug which actually helps to slow down the decline in renal function. And therefore, it's no big surprise that on April 30th of this year, the US FDA approved Dapagliflozin to reduce the risk of adverse kidney and CVD outcomes in patients with CKD. And Dapagliflozin notably is the first SGLT2 inhibitor to be approved by any regulatory agency for patients with CKD, irrespective of the diabetes status. And we'll be hearing more about that. So even if you don't have diabetes, nephrologists have started using this. And the DAPA CKD trial was also the first SGLT2 inhibitor trial in patients with proteinuric CKD with and without diabetes. Next slide, please. So going on to this, the question will then come, then why aren't more people using this drug? If such a a miraculous drug, why aren't we using this more? And perhaps one of the reasons why we are having webinars like this is to sensitize physicians and to reduce physician inertia in case they have any reservations about using these newer molecules. Because we must tell the clinician that now they have additional therapy to modify the prognosis in CKD patients. Next slide. Next slide, please. So who are the agencies and what are they saying about this? This is the ADA 2021 guidelines. And if you look at that, see earlier, just 4 or 5 years earlier, when we had the guidelines for treatment of diabetes, you will all remember that we had metformin there on top as the first line. And then after that, they give you a choice of about 6 or 7 drugs, which included the sulfonylureas, basal insulin, thiazolidinediones, the GLP-1 receptor analogs, the DPP-4 inhibitors, SGLT2, and they said you choose. Whatever you want, you can choose. So that was not the era of precision diabetes or precision medicine. You choose whichever you want, whatever you feel like taking, you can take for your patients. But now they've started considering what does the patient have? Does the patient have atherosclerotic cardiovascular disease? In which case, you can prefer a GLP-1 receptor analog or an SGLT2. And then if you have a heart failure, no doubt at all that the SGLT2s have been proven, have the best proven benefit in this particular population. And therefore, it comes right on top, even above the GLP-1 receptor analog. And then if you have CKD, again, the SGLT2s are put there, saying that if you have any evidence, of benefit. If you want a patient to have the benefit of reducing CKD progression, then you include this particular drug. And of course, there are other categories if you need to minimize hypoglycemia or weight gain as an issue or cost is a factor and so on. But right here on top, the topic of our discussion is CKD. And you can see that in patients with albuminuria, they say preferably you should be using an SGLT2. In fact, we now go to the extent of saying that it may be difficult in a court of law today if a patient challenges you and say that I went into renal failure and my doctor never gave me this drug. We might have a difficult time even justifying it, why we did not use it in that particular patient. So that's the power of evidence in clinical medicine. Next slide, please. So apart from, so these are the key guidelines about which I'm sure Dr. Jha may be talking, or Dr. Subhankar Chowdhury may be talking about that. So when you talk about the first line drug along with metformin in the treatment of diabetes and CKD, of course, you still have the lifestyle, physical activity, nutrition, if you're obese, weight loss, all those are there. Metformin can be continued as a first line unless the eGFR is going down to below 30, or if there is dialysis, then you should discontinue it. Below 45, we normally don't use very high doses of metformin. But then, along with that, now the SGLT2 drugs are added till a eGFR of 30 is reached. So if it is below 30, eGFR of 30, we avoid the SGLT2s. In fact, we probably avoid all oral drugs and use only insulin. And then, of course, currently in the stage of dialysis, these drugs are also not recommended. So you can see that now it has taken a step above all the other drugs that you may use in the treatment of this particular clinical situation. Next slide, please. So coming to a word about the DPP-4s in the management of DKD, we have always known that these are gentle drugs. They can be used in any stage of diabetes. The risk of hypoglycemia is very, very low with these drugs. And now we know that perhaps these drugs, the DPP-4 inhibitors, may also have, at least they are neutral on DKD, but they may also have some beneficial effects in DKD. And therefore, in this particular webinar, we'll be discussing both the molecules, talking a lot about the SGLT2s and Dapagliflozin, but also about the DPP-4 inhibitors in general, and probably about Vildagliptin a little bit more. And there are some studies which have shown that there could be improvement in albuminuria also, suggesting that the DPP-4 inhibitors may have one shade improvement compared to the older anti-diabetic drugs in the management of DKD also. Next slide, please. So today with that just 4 or 5 slides so that you all come on to the same page. The main job of today evening is for me to sit back and relax and listen to these two stalwarts in the field. And therefore, it's my pleasant duty now to introduce my good friend and colleague, Professor Subhankar Chowdhury from the city of Kolkata. He is the head professor and head of the Department of Endocrinology at Kolkata at the IGP, MER and the SSKM Hospital. He also holds several other positions. He is associated with the CDS CEO, Government of India, is a founder patron of SAFES, or the South Asian Federation of Endocrine Societies, the immediate past president and editor-in-chief of the Indian Journal of Endocrinology and Metabolism. He's immediate past president of the Endocrine Society of Bengal. He's a past president of the Endocrine Society of India. He has several research interests, including gut microbiome, gestational diabetes, and several other parts. He has over 200 publications in peer-reviewed journals. What I'll do is I'll also introduce the next speaker, and then we can get on to the rest of the program. The second speaker is going to be Professor Vivekanand Jha, who is the Executive Director of the George Institute for Global Health. He holds many positions, including a faculty position in the Imperial College London. He's a president of the International Society of Nephrology, the highest position you can hold for any nephrologist in the world. He has wide-ranging research interests, including the understanding of societal impact kidney disease. I think he has the only data on end-stage renal disease and the prevalence of CKD in our country and globally. He closely works with many, many organizations, including the WHO, to develop clinical guidelines, advocacy papers. I've had the honor of working with him on several associations and committees and so on. He's a very well sought after speaker, and he has written extensively in many, many journals, including the Lancet and many others. So we have two very, very eminent speakers. So I don't wish to stand between you and the speakers. So can we go on to the next slide? Maybe Professor Subhankar Chowdhury, you can now take over from here. So
you please help Dr. Subhankar Chowdhury's slides to move.
Okay, that will be wonderful.
Yeah.
Thank you very much, Dr. Mohan. That was a wonderful beginning, and I'm sure my little job will be made much easier by what you've already provided as introduction. I'll share my slides. And of course, this evening actually belongs possibly primarily to Dr. Vivekanand Jha, but I'll try and play along and at least try and show safety and efficacy in terms of glucose management with DPP-4 inhibitors. And our focus will be Vildagliptin. Before we go, I don't know whether the system will allow, can we have the audience participating in a single question poll? Can we have the poll? So the question essentially is for each one of you, in your opinion, do you consider Vildagliptin as a safe and effective anti-hyperglycemic agent in CKD with diabetes or diabetic kidney disease, DKD as we call it? And can we have the polling on, and can we have maybe up to 60 seconds? And then I'll go on to my presentation, and we shall relook at this poll results at the end of my presentation. So maybe I'm setting myself a challenge. Since I cannot see the poll, I hope this is on. Dr. Kunal?
I'm not.
Sir, yeah, your slide is visible. Sir, you put the next slide. You tap the button of next slide.
No. Are we having the poll?
Maybe it's in
your audio is also clearly visible. Audio is also clear.
No, I do understand. Anyway, no. So I'll go on to my.
I think the question Dr. Kunal, Professor Chowdhury was asking is, we are not seeing the poll question on the screen. So are you going to put the poll question on the screen? That is the question Professor Subhankar Chowdhury is asking.
No.
How will they vote unless you put the poll question?
Yeah, Karthik.
Sir, you can ask the question. They can give the answer in the live question section over there.
Oh, okay.
Okay, is that the way? So I've already asked the question.
I think
maybe...
I've got the answer also. So I think I've just got the answer also. So they have heard your question and they replied. So 57.8% of people, before they have listened to you, Professor Subhankar Chowdhury, have said yes to the answer. So they
undecided?
Yes, we can use it. No is 13.2. No, and undecided is the rest, about 29%.
Right, great. Okay.
So we hope undecided and the no's might change.
Let's not necessarily. Right. So the brief sort of the agenda. First, a little bit about diabetes and CKD. Again, Dr. Mohan has already referred to that. DPP-4 inhibitors in the management of DKD, possibly in the management of hyperglycemia in individuals with DKD. Then specifically home on to Vildagliptin patients with renal impairment. Look at efficacy and safety of Vildagliptin in renal impairment, and then finally conclusion. So we all know that diabetes, kidney disease contributes very significantly to the overall burden of CKD across the globe, in our country as well. What is also important to know and appreciate is that we have two different components of DKD. One is declining eGFR, measured from a serum creatinine and then put into a formula. Usually software will give you immediately a result, an app, as well as albuminuria. And both of these are independent risk factors, not just for renal impairment, but even for adverse cardiovascular outcomes. This is something we need to remember. And there are various figures that people with diabetes kidney disease are several times more likely to die prematurely and most often from a cardiovascular event than actually to reach end-stage renal disease. And as it is, we know that end-stage renal disease is a difficult condition to manage, especially in our country, with resource constraints in terms of the number of places where you can get expert treatment for DKD or end-stage renal disease, and also for, on the point of affordability of patients. And so the mortality risk is increased by at least 30% in patients with diabetes along with kidney disease. And the other important issue is in presence of renal impairment, there is higher risk of a patient experiencing hypoglycemia. So these are considerations which would sort of determine our approach to treating hyperglycemia in someone with diabetes kidney disease. And as far as the figures are concerned, we have a figure of 34.4% of DKD in our country. However, there is no fixed figure. It's anything from maybe 30 to 40%, I would say. And theoretically, at least, and on the basis of excellent, elegant animal model studies, the DPP4 inhibitors could be well suited to provide kidney protection. And Dr. Mohan has already mentioned to its potential role. And these are partly GLP-1 dependent. We know DPP4 inhibitors provide their glucose lowering effect primarily by increasing the level of GLP-1, not as much as would be seen with GLP-1 receptor analogs, but maybe increase it by 2 to 3 folds. But the kidney protection, potential kidney protective effect would be seen even on GLP-1 independent lines, mainly by decreasing TGF-beta, which decreases epithelial to mesenchymal transition and therefore reduces fibrosis, improving the levels of SDF1. We know DPP4 not only acts on GLP-1 to break down, to inactivate, it also acts on a number of factors, including SDF1. So if you inhibit DPP4, you also improve the levels of SDF1. And SDF1, without the need to go into details, is an important factor, stromal cell-derived factor, which has important tissue repair effect. So it could well give rise to better tissue repair. And then, of course, GLP-1 dependent mechanisms could give rise to improvement of hyperglycemia, of course. And then, of course, decreasing NF-kappa B, decreasing protein kinase C beta, decreasing oxidative stress, decreasing cytokines, and so on and so forth. So theoretically, at least DPP4 inhibitors, including vildagliptin, could have anti-fibrotic, anti-inflammatory, and antioxidant properties. In terms of the use of DPP4 inhibitors, in general, as a class, they are effective, they're well tolerated for management of hyperglycemia with any degree of renal impairment. The potential benefits, of course, are there because of these likely anti-fibrotic, anti-inflammatory, and antioxidative stress properties. And there are some studies which have suggested that albuminuria improves with the use of DPP4 inhibitor. And we know albuminuria itself sort of tends to perpetuate the renal damage. And so if you decrease albuminuria, potentially you may be able to protect the kidneys. So, quick look at Vildagliptin. Of course, this is an old molecule. Now it has gone out of its period of exclusivity, approved in 2008. We know there are different classes of DPP4 inhibitors. It belongs to class 1. And it is incidentally one of the most extensively studied DPP4 inhibitors in terms of clinical utility. It has numerous papers, numerous large numbers of patients have been exposed to this molecule. So we do have the confidence of using it over the last more than 12 years. And just one slide, possibly to look at the efficacy. So we are talking of efficacy. On the left is in moderate renal impairment, on the right is severe renal impairment. And we are comparing placebo to Vildagliptin 50 milligram once daily. And what we find in either case, there is a significant HbA1c difference. The placebo appears with the open circles, and the black triangles represent Vildagliptin. And there is an HbA1c effect or lowering of HbA1c by about 0.5 to 0.6%. And then if you look at Vildagliptin clinical trials in diabetes with CKD, we do have a fair number, including in patients with EGFR less than 30 milliliter per minute. And you have what we have here is the number of subjects shown here. And we see there is a consistent improvement in A1C across the board, across all levels of renal function, moderate to severe. So we are assured that it remains effective in presence of CKD, even fairly advanced stages of CKD. And of course, I don't need to bring coal to Newcastle in front of this august audience. We all know the benefits of reducing A1C on complications. This is an extrapolation from the famous UKPDS, which sort of extrapolated 1% reduction in A1C could lead to significant improvement of diabetes-related complications. In fact, even macrovascular complications would theoretically be improved, would be impacted upon, but at least very strongly the microvascular complications. And then we have established that Vildagliptin does have the evidence of being efficacious, even in presence of renal failure in those who have got diabetes. Now we look at the safety part of it. And this was the Gallant study, which basically looked at Vildagliptin as add-on to metformin versus thiazolidinedione as add-on to metformin. And what we are looking at is the black bars are representing normal renal function. The gray bars represent mild renal impairment. And if you look at the drug-related adverse events, it's the Vilda metformin part. There isn't significant difference between the two groups, and possibly maybe TZD and metformin, maybe the drug-related adverse event are slightly more, but that's not significant. So we are also assured, and there are other studies as well, which have established that it is safe to use Vildagliptin in patients with renal impairment as well. And this is not the verified study, is not directly related to use in renal impairment, but this looks at early combination therapy of Vildagliptin with metformin versus sequential metformin monotherapy, followed by later addition of Vildagliptin if needed in newly diagnosed type 2 diabetes. And what it did show was that this early combination treatment seemed to do much better than sequential addition of agents in terms of a better A1C achieved at the end of 5 years. So what it suggests essentially is if we could sort of get a better glucose control earlier on, and we all know about the legacy effect, we might be getting patients to have less of the complications in the long run. Now, what about dose adjustment of the DPP4 inhibitors in CKD? Now, this table shows 5. We in our country also have teneligliptin. We also have evogliptin. But these are the internationally available 5 major gliptins. We see apart from linagliptin, all of these in CKD generally below an EGFR of 50 ml per minute will require a dose adjustment. Vildagliptin is the one that is conventionally, classically used twice in a day, and it will now, in presence of EGFR less than 50, would be used once in a day. And it goes on, the same dose goes on even to EGFR less than 30 milliliters per minute. And the adverse events are quite low, as we see with all of them. With vildagliptin, the advantage actually now in presence of CKD is that instead of having to give it twice, you can give it once, just like all the other DPP4 inhibitors. So in presence of CKD, I think vildagliptin will have a special role because you reduce the number of doses per day. And we can, this is about the same, the early combination therapy. And there are a number of, as I said, it was not just the Gadient, there are a number of different meta-analysis which give us good assurance of the safety of vildagliptin in renal impairment. And there are unique benefits of vildagliptin, especially I would highlight useful for difficult to treat patients over 75 years because of the evidence base that we have with vildagliptin in this class of patients above 75, which comprises a significant number of patients, especially who are also in CKD. So we will conclude that vildagliptin amongst the DPP4 inhibitors has possibly the largest amount of data in patients with moderate to severe renal failure. It is good efficacy, good safety, and especially also in patients above the age of 75. This is of clinical relevance since a large proportion of diabetic patients are frail and also suffer from kidney disease. And it has potential, at least because of improvement in markers of oxidative stress and inflammation, and the likely cardiac safety, that it could be an effective choice for type 2 diabetics with mild to moderate renal failure. Of course, at this point of time, I don't think there is the strength of evidence to suggest that it will actually alter the course of renal impairment, but definitely it's proven that it is safe and effective. And what I would like to add is there is further cost reduction and convenience in patients with significant renal impairment, where we are reducing from twice a day to once a day vildagliptin. So cost becomes less, usage of drug is easier. So with that, I'll rest my case, and I would like maybe to revisit the question. In your opinion, do you consider vildagliptin to be a safe and effective DPP4 inhibitor, safe and effective anti-hyperglycemic agent in diabetes kidney disease? And maybe the poll can start now, and we could give ourselves a few, maybe 30 seconds to have the answers. Thank you very much for the opportunity.
Thank you, Professor Chowdhury, for that very nice presentation on vildagliptin. And let's wait for the poll to come in. I don't want to influence them by saying anything now. So let's just give it a few seconds and wait for them to come back.
Have I just a second? Yeah.
Okay, so the yes has gone up from 57.8 to 68.9. The no has come down from 19 to 9.7. And they've been honest. The undecided 29% to 21.4. So you are right. Not too many people, but a few people have been convinced. Before Dr. Jha, starts his talk, and I suppose he'll be talking more on DAPA and the SGLT2 and the kidney part of it. My own take on that is that, of course, for DAPA, we have much more evidence that it actually benefits the kidney. And it's not that every drug has to benefit the kidney. These are not meant to be kidney drugs. So if metformin doesn't, help the kidney, or the sulfonylurea doesn't help the kidney, they're not bad drugs. They're not meant to be anti-diabetic drugs. And therefore, if a DPP-4 inhibitor is safe from the kidney point of view, if we can use it safely even in up to almost, late stages of DKD, if it doesn't produce hypoglycemia, and it's a safe drug even in elderly people, what more do we want? And and they work better in Indians. That's another thing that we have shown. The DPP-4s seem to work better in Asians. Now we have some evidence that the SGLT2s also work better in Asians. So all in all, it's a safe drug. It can be used. It can even be combined with other drugs, including the SGLT2s. And therefore, I think that's how we should leave it, instead of pushing it and saying that this is a drug for kidney. I don't think it's really fair to say that. But if you just say, yes, it might have some additional benefits, but certainly we know it doesn't do any harm, and it's a very safe drug which can be used. I think that would be the right way to take it, and I'm glad some of them stuck to it and said, no, I'm still undecided. But of course, using it is not an issue, and they might have to be a little dose reduction also, but otherwise it's a safe drug. Okay, so having said that, now let's move on. I've already introduced Professor Jha. So Professor Jha, you'd like to share your slides, and can you get on with your talk now?
Sure. Thanks, Dr. Mohan. Are you able to see my screen?
Yes.
Right. Wonderful. Thank you. Thanks, Dr. Mohan, first of all, and to Dr. Subhankar. And Dr. Mohan, thanks for setting up this talk by asking the question, what more do you want? So, of course, the more thing that you want is organ protection. You just don't want blood sugar control, because blood sugar control is no good if your organs are not protected. All of us manage patients not just to get their numbers down, but to make sure that they live longer. And so there is always this quest to find a new drug that is able to do that. So let's see where Dapagliflozin or other SGLT2 inhibitors stand in that line. But before that, I would also like to convey my thanks to Panacea team for organizing this particular educational event, which is really very, very important, because we do need to be educated not just on the drug, but how to best use a drug. Having a toy is not important. Knowing how to best use that toy is also important. So you have already all heard about how common kidney disease is, and we do want to prevent the progression of kidney disease. And for the last 25 years or so, we have had only one particular class of agents, which is the RAS blockers, both renin-angiotensin converting enzyme and angiotensin converting enzyme inhibitor and angiotensin receptor blockers. And these two trials that were the pivotal trials that established these agents came in the 90s, as you can see. And both the trials show that while the risk of development of end-stage kidney disease is reduced by use of these agents, a significant residual risk still remains, and patients have continued to progress on to advanced kidney failure and develop cardiovascular disease despite our increase in the use of these particular agents. So then it was not until recently that we had the next shining molecule, which is the SGLT2 inhibitors. And in 2019, the World Congress of Nephrology saw the presentation of Credence trial. I'm sure you're all familiar with this study. Credence trial was in patients with diabetes and chronic kidney disease, varying degrees of chronic kidney disease. And you have the inclusion exclusion criteria on the left side here. These people were all put on maximal dose of ACE inhibitor or angiotensin receptor blockers, and then randomized to receive either canagliflozin or placebo. And the primary outcome was a composite cardiorenal outcome, which is doubling of serum creatinine, end-stage kidney disease, death due to cardiovascular and kidney disease. What this trial showed that in diabetics with chronic kidney disease, canagliflozin reduced the risk of this composite endpoint by 30%. And you needed to treat 21 individuals to reduce one composite endpoint. Similarly, canagliflozin reduced the risk of development of end-stage kidney disease by 32%. And the NNT, number needed to treat, here was a little higher because the uncertainty was greater in this. And importantly, for the first time, it showed there was no increased risk of amputation or fractures, which had initially been shown in the CANVAS program. So as a result of these findings, many guideline organizations changed their guidelines for management of diabetes. And KDIGO, which is the kidney organization that brings out these guidelines, revised their diabetes management guidelines in 2020, saying that you should use SGLT2 inhibitors in most patients with type 2 diabetes in association with RAS angiotensin blockade. Of course, I wouldn't omit the fact that we need to make sure that blood pressure control, smoking cessation, lipid management, exercise, etc. are important. It went on again to say that after initial advice of physical activity, nutrition, and weight loss, the first line therapy includes metformin, which Dr. Mohan was at pains to point out is important, but should also be combined with SGLT2 inhibitors. And only then additional drug therapy, which includes GLP-1 receptor agonists as the preferred agent, should be added for glycemic control. And a similar, this is a busy slide, and I wouldn't want you to get into the details, but a similar statement was made by the American Diabetes Association in 2021, which says on the left side here, consider independently of baseline A1C, individualized HbA1c target or metformin use in people with diabetic kidney disease and albuminuria, preferably SGLT2 inhibitors, etc. So that was also recognized by the endocrine community. And so this is something which I'm sure you're all familiar with as endocrinologists. Then came this trial for nephrologists, which really is forcing us to change the way we think management of chronic kidney disease outside of diabetes, because until recently, these flozins were considered to be anti-diabetic drugs preferentially. So the DAPA-CKD trial was the first SGLT2 inhibitor trial in patients with chronic kidney disease with and without diabetes. And once again, it has a composite cardiorenal endpoint, which is shown here, but it had a range of other secondary endpoints also, which are listed here. You can see that subjects were recruited from 21 countries, more than 4,000 participants, including from India. 200 patients were recruited from India as well. But you can see the range of countries from where these patients were recruited on this particular slide. And this is the study design: adults, EGFR between 25 and 75, USCR between 200 to 5,000, and all had to be on maximally tolerated dose of ACE or ARB for 4 weeks or so. People with type 1 diabetes, polycystic kidney disease, lupus, and ANCA vasculitis were excluded, as were those who had been on immunosuppressive therapy. And again, they were randomized 1-to-1 to receive matching placebo or DAPA 10 milligram once a day. The analysis was on intent to treat principle, and this study actually was prematurely stopped by the Independent Data Monitoring Safety Committee because of overwhelming benefit of the drug. These are the baseline characteristics, and the point to show these kind of slides is that just the randomization worked. These are people with the mean age of about 62 years, about 1/3 were female, and most were type 2 diabetes, and you can see the other. So this is the key slide from this particular study in terms of primary composite endpoint, which is what this trial was designed to study. There was a 39% reduction in the relative risk. You can see the number of events in placebo on the top gray line and in DAPA treated subjects in the purple line. And what it meant was that you needed to treat 19 patients to prevent one composite endpoint. So this is very, very powerful, which tells us that we should be using DAPA in the population, the kind of population that was studied in this trial. Then we came to the main secondary endpoint, which was dialysis, kidney transplantation, or renal death. And even there, the hazard ratio was 0.66, which means 34% risk reduction, quite statistically significant. You can see the p-value. Then we looked at the other components of the endpoint, and in all the other components, such as greater than 50% EGFR decline, end-stage kidney disease, chronic dialysis, and EGFR less than 15, you can see that the magnitude effect all falls to the left of 1, which means that patients who were treated with DAPA were overwhelmingly benefited by its use. The only specific endpoint which crossed this line of 1 was cardiovascular death. Further, a pre-specified subgroup analysis showed that dapagliflozin worked in those who either had type 2 diabetes or did not have type 2 diabetes, or irrespective of the degree of albuminuria. Those with relatively lower amounts of proteinuria also received benefit. In fact, the benefit there, if anything, was somewhat greater. You can see the hazard ratio 0.54, and in those with a higher degree of albuminuria, 0.62. Secondary outcome, cardiovascular death or heart failure hospitalization, again, significant difference. So not only kidney-specific endpoints, but cardiac-specific endpoints are also favorably influenced by the use of dapagliflozin. All-cause mortality better in dapagliflozin-treated patients, 31% reduced risk of death due to any cause. So this is the summary slide that shows the answer to the question, could dapagliflozin improve kidney and cardiovascular outcomes in patients with CKD, which is what the DAPA CKD study started with. This was the question. And you can see there was a 14.5% in prevalence of primary composite outcome in the placebo and 9.2% in the treated arm, 11.3% and 6.6% for the composite kidney outcome. Composite cardiovascular outcome 6.4% and 4.6%, and death from any cause 6.8% and 4.7%. So consistent reduction with the use of dapagliflozin in all the clinically important endpoints. So according to a poll in the nephrology community, when this is something which you had a poll in the previous talk. So all the top nephrology stories are polled. And guess which study came at number 1? It was the DAPA CKD study, because it was thought to be so important in the nephrology community. And in summary, the conclusion of this particular trial was that in patients with chronic kidney disease, with or without type 2 diabetes, DAPA would reduce the risk of kidney failure, reduce the risk of death from cardiovascular causes or hospitalization for heart failure, and it prolonged survival, which means it reduced mortality. I didn't mention it, but dapagliflozin was well tolerated in the study in keeping with its established safety profile. So just worth mentioning here that initially in the CANVAS program, there was a fear that dapagliflozin treated patients will develop acute kidney injury, but now there is study to show that several studies have shown that is not indeed the case. If anything, people on dapagliflozin have a reduced risk of developing acute kidney disease. So as a result, as you saw, dapagliflozin already was approved for treatment of kidney disease, not only kidney disease, but type 2 diabetes and heart failure in those with diabetes. But after the DAPA CKD study, US FDA approved to include on its label reduction in the risk of sustained eGFR decline, end-stage kidney disease, and cardiovascular. So this is the first Reno-protective drug, specific Reno-protective drug after ACE inhibitors and angiotensin receptor blockers. And this particular slide simply shows you that there is another study currently underway, which is EMPA kidney study, which is the study of heart and kidney protection in dapagliflozin, which is going to even expand the indication of the use of dapagliflozin in terms of the patient population it is recruiting if this study is successful. So we are continuing to wait for the results of this study. The study is expected to recruit until September 2022, and then we'll probably see the results sometime in late 2022 or early 2023. So just one slide to show the mechanism of SGLT2 inhibitors in CKD management. And I'm not sure that you are necessarily so keen to understand the mechanism as long as it works, but it's always good to know that. And people are feverishly conducting studies to understand that. And this slide is just meant to show that we don't fully understand the mechanism of reduced chronic kidney disease protection, but there are multiple mechanisms which have been suggested. One of the favored one is potentially beneficial effect on the tubuloglomerular feedback, but then there are a number of other indirect effects, which is loop diuretic sparing effect, reduction in albuminuria because of the reduced tubuloglomerular feedback, which reduces the toxic effect of proteinuria on the tubules. It can potentially also reduce the demand for solute transport. It increases hematocrit and oxygen delivery to tubular cells, and it has an anti-inflammatory and anti-fibrotic effect. It can improve energy substrate utilization. And of course, it has a positive effect on blood pressure. It reduces endothelial dysfunction and arterial stiffness. It has obviously cardiovascular effects as well. And if the heart is healthy, the kidney is also happier. In terms of safety, as I said, dapagliflozin is generally quite well tolerated. And the most frequently reported adverse events that we need to watch out for are female genital mycotic infections. And urinary tract infections were a worry, but I think the urinary tract infection concern is getting less and less. But you should still be watchful for UTIs in elderly individuals, those who have had recurrent UTIs, and of course, female patients are at greater risk. But most of these patients do not require discontinuation of this treatment. So therefore, ladies and gentlemen, in conclusion of my talk so far, that in light of the results of these studies, dapagliflozin is now has been established to have a central role in the management of chronic kidney disease. It is, of course, the first Hlt2 inhibitors to be approved by US FDA or other regulatory agencies. But what we need, as I said, is not just to know that this particular drug works, but how can we best use this drug in our clinical practice? So educational events of this type are really important in disseminating and responsible implementation of these molecules. They should not be used indiscriminately. They should be used discriminately so that patients who need these drugs the most are able to get them, because everything adds to the cost of treatment. And going back to Dr. Mohan's point, SGLT2 inhibitors clearly have stopped being primarily an anti-diabetic class of drugs. So SGLT2 inhibitors are now primarily reno-protective and cardioprotective agents, which you might use for this purpose in those who have or do not have diabetes. Glucose lowering is merely a side effect, which will be of benefit to those who have diabetes, but those who do not have diabetes also potentially merit the use of this particular agent for cardioprotection and renal protection. I'm going to stop here, and I think we can move on into the question and answer session and have further discussion.
Thank you, Dr. Jha. Side effect probably is where you come a full circle now. We used to say that it produces gentle side effects, and so now the glucose lowering has become a side effect. Okay, so I have, in fact, I know I'm conscious of time, and I know that on a during weekend, we should not take up too much of people's time. But we have started getting a number of questions which have been sent to me. So let me take up a few questions, and I'll alternate between Dr. Chowdhury and Dr. Jha. So the first question to Dr. Chowdhury. Please, this is from Dr. Vikram Das from West Bengal. So he wants to know, it's your state. So please clarify on the patient profile for selection of these drugs, he says, and what is the situation where they're contraindicated. He probably means both the drugs. So you can probably take Vildagliptin and also give your view about SGLT2. Where are they? What is the selection? Where will you select? Where will you not use these drugs?
Yes, that's a good question, but also that covers a vast area. So essentially, the strength of this class of drugs, so I'm restricting myself to DPP4 inhibitors, is their efficacy, but which is in terms of glucose lowering, which is modest. And however, advantage is they do not cause weight gain, and very importantly, do not cause hypoglycemia. So we can use it in any patient with type 2 diabetes, as we have seen across the range of renal function, where the A1C target is maybe 0.5 to 1 above sort of the A1C currently is 0.5 to 1% points above your target. Because, as I said, they are not very powerful glucose lowering agents. They can be used in obese, they can be used non-obese. We have seen they can be used in young, they can be used in old as well, which is because of its safety. Of course, we need to make sure it's type 2 diabetes, which is not meant for type 1 diabetes. We are clear. In terms of cardiac event, especially in the context of cardiac failure. Now, Vildagliptin per se doesn't have a big cardiovascular outcome study. However, it has a large sort of database, at least from pre-registration studies to post-registration studies, and have generally been shown to be safe. And in presence of cardiac failure, especially, possibly, I feel they are safe. Vildagliptin is safe, but will clearly not be the first choice agent. In such a condition, definitely we will have to think of SGLT2 inhibitors as an anti-hyperglycemic agent. So I think that is sort of my comment. I specifically asked what is a contraindication, specifically where should we not use it. Now, at this point of time, still the sort of stigma of acute pancreatitis with DPP4 inhibitor class of drugs is there. Though if you ask me my personal opinion, I haven't seen much of that. But if someone has a history of acute pancreatitis in the past because of a wide choice that we have got, I would possibly not be using in those individuals.
Thank you, Professor. I think that is very fair. We have seen slight increases in amylase and lipase, but pancreatitis itself is quite rare. I mean, a couple of cases have been reported with this group of drugs, but it's so rare that it hardly matters. Maybe a couple of cases in India have been reported all these years. So let me go on to Dr. Jha. So Dr. Indranil Malik wants to know, can we use Dapagliflozin in stage 3 or stage 4 CKD? I know the indications are changing all the time, getting more and more data, but what is your view on that? And is there any definite contraindication to Dapa?
Thanks. So stage 3 CKD, definitely, there is no doubt about it. Stage 4 CKD, right now the label says that don't use in EGFR less than 25. And so if you use, it will be off-label use. And that is the exact question which is being currently investigated by the EMPA kidney study. So once the EMPA kidney findings come, we will know the answer. But there have been actually secondary analysis of the DAPA CKD study, which was published in Journal of American Society of Nephrology just last month, which showed that the subgroup of patients who had stage 4 CKD also experienced benefit from the use of SGLT2 inhibitors. So currently, by our knowledge, don't start SGLT2 inhibitors new in anyone with EGFR less than 25. But I must say that if someone has been started on SGLT2 inhibitors and their GFR drops down to stage 4, or even unless they go to require end-stage kidney failure, the recommendation is to continue using SGLT2 inhibitors. So don't stop if they have progressed from stage 3 to stage 4, but don't start afresh if EGFR is less than 25.
Till we get more evidence, obviously. Okay.
Till we get more data, of course.
So, Dr. Chowdhury, back to you. This is a general question, not really related. I don't know why Dr. Nambiar is asking that, but Dr. S.B. Nambiar is asking, really and practically, with so many variables which are not under our control, diet, exercise, etc., why should we use, can we use HbA1c to modify our drug schedule? Isn't fasting and PP a better parameter? Maybe you can explain how they are both important.
Yes, so that's important. A very practical question. An easy answer is many a time patients, partly because we do not educate them well enough, they come to our clinic to essentially to keep us happy, to make the doctor happy, to give them a good figure. So it's clearly our failure that we have not made them understand that it's really for their benefit that they need to keep things under control. So many a time they may have gone off diet, may not be exercising, may not be taking medications, but soon before coming to the clinic, maybe the last 7 days, 10 days, they would follow everything and come up with reasonably good fasting and PP glucose values. So unless we did the HbA1c, we wouldn't really have picked out these individuals who were otherwise not controlled. So fasting PP also we do need. Actually, we need 24 hours glucose profile. Actually, but short of that, at least fasting postprandial and at least maybe done several times, not just one fasting and one PP, maybe several PPs, means breakfast, lunch, dinner. We should try and get as close to the time of consultation as possible. But we also need to be supplemented by HbA1c to give us an overall picture of the glucose control in the preceding maybe couple of months or so.
Couple of short comments. Today we have, apart from these, we also have continuous glucose monitoring. So not only a fasting and PP taken occasionally, like a snapshot, like a picture, photograph, but also like a video recording. You have your blood sugar reading, so you can check it at any time of the day. You can find it's getting hypos, hypers, everything. So continuous glucose monitoring has changed. Of course, you're right, Dr. Nambiar, that to adjust the doses, if individual blood sugar is more important. I'd like to give you another example that is like a class test versus a final examination. Okay, why do you have all these class tests? Because you improve your performance. So in the final exam, you do well. So if you keep controlling your fasting and PP very well, you'll get your HbA1c. Since the fasting PP is fluctuating every day, how do you know on an average whether you have done well or not? And that's why you have the final examination, isn't it? So where you're scored or a grade is given or something like that. That is what your HbA1c is about. So you can't cheat your HbA1c, and unless you get all these under control, you can't get it. So they are not competitive to each other, but actually supplementary to each other. So the next question is to Dr. Jha, and there are actually three questions in this from Dr. Hemanta Gogoi. He wants to know three things. One, can dapagliflozin reverse nephropathy? Number two, can it worsen UTI? Number three, is it contraindicated in obstructive nephropathy?
So the answer to these three questions is first, yes, it can reduce proteinuria in those who have established proteinuria. So to that extent, it can reverse. Can it reverse histological nephropathy? We don't know because we have not done biopsy studies. The second question was around UTI. So the UTI, it can increase mycotic infections, but true urinary tract infections, the evidence is getting less and less strong that it can actually increase the risk of UTI, except in the elderly and elderly females specifically. The third question was, is it contraindicated in obstructive nephropathy? No, there is no contraindication. It can be used in CKD due to any etiology as of now. So these patients are not excluded from the DAPA CKD trial.
Okay, now since we are over the time, we'll have rapid fire questions. So to Dr. Chowdhury, yes, no. In elderly CKD patient, can combination of metformin and vildagliptin be used?
Yes, depending upon the stage of CKD, less than 30, we would not use the metformin component of it.
Wonderful. Then to Dr. Jha, is there any age limit for use of dapagliflozin 5 milligrams in type 2 patients?
No.
Dr. Jha?
Adults, just adults,
Just
right? No, not in children.
Okay. And adults, is there any age limit? So
no upper limit.
No upper limit. So even an 80-year-old person you can give.
Yes.
Yep. Okay. So the Dr. Joseph wants to know, and this is to Dr. Chowdhury, does vildagliptin score better than sitagliptin in mildly renal compromised patients?
That's not correct. That's not fair. No.
Okay. Then, okay, I think there are others which is better, Lena or Vilda and CKD. Obviously, Lena has a better track record. Can Vilda and DAPA be started as first-line drugs?
So if the person has either chronic kidney disease or cardiovascular disease risk factors, we should always prefer using Hlt2 inhibitors. And if the blood sugar is not controlled, then go on to use other agents. In fact, this particular class of agents is slowly sliding down in the list of priorities, unfortunately, even though we have this featured in this presentation. It is, unless the glycemic control is really bad, it won't be listed very high in the list of priorities.
Okay. So I think we have had a fair discussion. We have tried to be as, non-controversial and as objective as possible. in the answers. Obviously, there was a focus on Vildagliptin and the Dapagliflozin rather than the class itself, and that's what the company wanted. But nothing wrong in it for two reasons. Number one, Vilda has now gone off patent, and therefore it's the most popular drug. And Dapa is also available now, as it's also gone off patent, and therefore, or rather, there are many companies producing it, and therefore they are the most available to the Indian audience, at least, as compared to the rest of the world, where it may not be so freely available.
So, and
Therefore,
just to interrupt, Dr. Mohan, Dapa is the only flozin which has received the label for CKD.
That's true. So label has been received only for CKD. So I think we have had a fair discussion from the number of questions which have come up. I omitted questions, can sulfonylurea still be used? And that's not the topic of today's discussion. And obviously, all drugs have their good and bad. So we are not saying that a particular class is bad or should not be used and so on. Today's discussion was on a focused discussion on Vilda and Dapa. So with that, I'll now hand it over to Dr. Kunal for the closing remarks. Thank you. And I'd like to thank both the speakers, Dr. Chowdhury and Dr. Jha, for giving excellent presentation. Very limited time allotted to them, but they've done a marvelous job, and I'd like to give them a round of applause. Thank you.
Thank you, Dr. Mohan. And of course, Dr. Jha. Wonderful to listen to you.
Thank you very much, Dr. Mohan, for excellently coordinating and chairing this session. Special thanks to Dr. Professor Subhankar Chowdhury for enlightening on the usage of Vildagliptin, importantly among the DPP-4 inhibitors in CKD patients. And thanks to Dr. Vivekanand Jha, with whom I'm interacting from our transplant and nephrology BU for long, as the panacea-biotic is one of the important in immunosuppressants like cyclosporine and Pangraph. So sir is always there on the academic front, and excellently you have stated. And what I liked most is that controlling hyperglycemia is a side effect of Hlt2 inhibitor. And this reminds us of pharmacologists that the side effects can make a drug the blockbuster. Example is sildenafil. And I hope Dapagliflozin, as getting the direct indication of non-diabetic indications like cardiovascular and renal, means CKD or diabetic kidney disease, DKD, importantly, is very wonderful. And I think you are just one slide and one word is new era of next coming one decade, as we have seen every decade as in anti-diabetic agent ruled by one class of drug, say for insulin, metformin, then glitazones, then DPP-4 inhibitors, and now SGLT2 inhibitors. I still remember that when I was in GSK in 2002, I presented the experimental study of SGLT2 inhibitor in 2002. And today we see that the largest use of when we talk about the microvascular and macrovascular complications of diabetes, we got the one diabetic patient's hyperglycemia and multiple complications. Today we got the one drug which is controlling diabetes and controlling multiple complications. And this is a great because of three of your discussion, our enlightened audience got that definitely the percentage how it has increased, and I'm very sure the percentage of the doctors will increase to use Dapagliflozin in diabetic patients with multiple complications. On behalf of panacea-biotic and our Diacar division, the Vildagliptin will act XR, Dapagliflozin Dapa, and we are for more than 2 decades with the glyclazide, glycid, M and glycid range. We are always there to providing you the excellent academic platform regularly. And I wish all our audience, thank you very much, and the great evening and great weekend for this seminar. So on behalf of panacea-biotic, I extend our vote of thanks, and thank you very much, sir. Dr. V. Mohan, Subhankar Chowdhury, and Dr. Vivekanand Jha.
Thank you. Bye-bye. Stay safe.